Thank you, Dr. Rolika. So what I will try to do over here is
you're on mute, sir.
Yeah, so when you look at the list of cases that you get in an exam, it's a very long list. And what I thought I'll do is I'll just tell you what is the minimum that we would like to know as examiners when you are examining a case. And obviously the minimum is what we need for glaucoma diagnosis and what we need for management. So when you look at diagnosis, you're looking at classifying it as either developmental or primary open angle or angle closure, or secondary open angle or angle closure. So the two important things there are the status of the angle, and the second is whether it is primary or secondary. And this is information you will need to get from your clinical evaluation. And your clinical evaluation starts from history. Your age at diagnosis will tell you whether it is more likely to be a developmental or a secondary glaucoma. Don't forget that most primary glaucomas are asymptomatic, including angle closure glaucoma. So if your patient has symptoms such as pain, headache, and other things, look for an acute glaucoma or look for a secondary cause. Always ask a history of trauma and a history of eye surgery. And of course, a family history is always helpful because that could also help you to assess which type of disease it is. The other important medical history for us is from 2 points of view. One is from the point of disease risk, and second is from the medication point of view. So you need to ask a history of asthma. You need to ask a history of heart disease because that will impact how you treat the patient. The history of thyroid or steroid use may give you a hint as to the etiology of the reason. Many of these patients will be on medication, and you should ask how often they use it, how regularly they use it, and what allergies they have, because these are all questions that will be helpful later in the examination findings. And in India, it's always important to at least know what the patient is doing, because you will have to start these patients on medication on a long-term basis, and your examiner could well ask you why you are prescribing an expensive prostaglandin when the patient can't afford it. When it comes to assessment of vision, don't forget that unless you have very poor central vision, visual acuity is usually spared till late in disease. So if you have poor central visual acuity and the damage is not that severe, look for another cause of decreased vision. We need to know why the vision in that patient is low. Don't assume it's because of glaucoma. The refraction will, of course, again help you to look for disease etiologies. A quick external evaluation is important. You might otherwise miss a scar close to the eye or a subtle hemangioma like this, which would give you the diagnosis in this patient straight away. Look at the lids and orbit again for signs of trauma or for signs of thyroid eye disease. And this will again help you with what disease is going on. A very careful evaluation of the pupils is important because a lot of primary glaucoma is asymmetric, and you might miss a relative afferent pupillary defect unless you look for it closely. And of course, always correlate with your clinical findings. A torchlight evaluation to look at the AC depth helps. It would give you a gross idea of what's happening. When you come to a slit lamp evaluation, look carefully at the conjunctiva. Many of us ignore that, but conjunctival congestion is a sign of many sort of secondary glaucomas and acute glaucomas. But what's equally important is that many of these patients can have drug-induced hyperemia or allergy, and you might miss it if you don't invert the conjunctiva and take a look. What's also important is to take a look for a bleb. You might see a completely scarred conjunctiva with a flat bleb, with a small, tiny peripheral iridectomy there, which you may even miss on evaluation. Something which is like this, which is a large overhanging bleb, is of course more difficult to miss. But if you see a bleb like this, don't also forget to look for a bleb leak, because that is part of your bleb evaluation in a glaucoma patient. At the slit lamp, look for thinning or scarring, because that would again give you a hint as to whether there's been trauma or whether there's any other etiologies that you need to look for. Always do the von Herrick grading. Look for the peripheral anterior chamber depth and grade it. And this is important because this is a fairly good way of assessing the risk of angle closure, but this is not a substitute for gonioscopy. You cannot make a diagnosis based only on a von Herrick test. When you look at the cornea, there are a few things that you need to look at. One is corneal edema. The presence of corneal edema could suggest either very high intraocular pressures or secondary causes. And when you have localized corneal edema like this, you are basically looking at a possible viral etiology. And it's important that you look at it. Look carefully at the endothelium, because you might miss a KRUKENBERG'S spindle, or you might this diffuse pigmentation, which is more common with pseudoexfoliation. Also, look for keratic precipitates. They will not always be this classic. You might just see a few specks here and there. And these are all hints as to what the etiology of this disease is. A good anterior segment evaluation is important, and that includes an iris evaluation. Something like this sphincter tears with a slightly sublux lens will tell you straight away what the etiology is. A retroillumination will tell you that this is pigmentary glaucoma you're dealing with. You have an iris bombé that will tell you that this is a secondary angle closure that you're dealing with. But more subtle changes, such as an accent field anomaly, will require you to look a little bit more closely, because this would indicate a developmental disease. So you need to look at the iris carefully before you take a call. Also look at the peripheral iris carefully, because you might miss an iridotomy which is sitting under the lid or under an arcus. Look at the edge of the pupil carefully, because you might miss subtle neovascularization. And these are important signs which will help you with your diagnosis. Look at high magnification at these two, and that is absolutely mandatory. When you look at the lens, an intumescent lens or glaucoma flecken will give you the diagnosis again in a fairly straightforward manner. But look for subtle signs of pseudoexfoliation. If you're getting a dilated pupil, sometimes you may not see very much on the pupillary rim, but you will see it on the lens. And if you see the lens edge somewhere, and if you see a myopic refraction, don't forget that microspherophakia with a secondary angle closure is probably what you're looking at. When you're looking at an intraocular pressure measurement, it's mandatory that you measure the intraocular pressure in every patient with suspected glaucoma. And ideally, measure it with Goldman appellation tonometry. Record the time of measurement, because that is important. And what is really good is if you can measure it twice or thrice and put down all those readings there, because that will give you an idea as to how reliable your pressure reading is. You will not have access to a central corneal thickness measurement, and this is something your examiner might ask you what you'd like to do, and don't forget at that point to mention that you might want to do a central corneal thickness measurement. Now, gonioscopy is a really important part of your clinical assessment, and while we are not covering it in detail in this session, there are a few things that I would like you to do. One is, don't forget that if you have the opportunity, do your gonioscopy in an undilated situation in a slightly dimly lit room. Use a short slit to ensure what are the structures that you're seeing. And that is in situ, without a bright illumination and without indentation. So look at the structures seen, look at iris contour, look at trabecular measured pigmentation, and look at peripheral anterior synechiae. This is best done with a indentation gonioscope, but even if you have a 2 meter or 3 meter gonioscope, that is fine. Do it under ideal testing conditions. And there are two main things that you need to do with gonioscopy. One is you need to look at the in situ angle. Like over here, you can see that the in situ angle is actually practically closed, but on indentation, it opens up. If you do not have access to a indentation gonioscope, one of the things that you can do over here is do manipulative gonioscopy to try and open up the angle. You need to do this because you need to figure out how much of the angle you can open up, and you will need to be able to record synechiae here or there. And your gonioscopy, you need to draw and you need to put down the amount of, it's always better not to use a single grading system, but to actually write down what structures you're seeing. Because different institutions, different examiners use different grading systems. Be aware of them, but write down what structures you're seeing in dim illumination, write down what structures you're seeing after indentation or in bright illumination. These two things are important when you're putting down your gonioscopy findings. Again, if you see any abnormality in the angle, such as angle recession or iridodialysis, don't forget to mark the extent of the angle recession or iridodialysis. If the trauma is subtle, you may not see very gross angle recession, and you would need to compare that with the fellow eye in order to be able to effectively comment on what is happening. Manish Singh very elegantly and exhaustively covered disc evaluation, and disc evaluation is essential in glaucoma diagnosis. He did mention that you need to mention disc size, and that's important. You need to look for disc asymmetry. You need to comment on the neuroretinal rim. It's good to mention at this point whether the isn't rule is followed or not. You need to comment on the optic cup. You need to comment on the color of the rim. You need to look at the retinal nerve fiber layer, and that's an important measurement. Look for optic disc hemorrhages and look for peripapillary atrophy. Some of these things is important to measure even as negative findings, saying no disc hemorrhages or no RNFL peripapillary atrophy, because that will tell you as to whether there are, that you have actually looked for it. Visual fields In some institutions, they would expect you to do a tangent screen, and you should be familiar with how you do it. You will know in your institution whether it's required or not. Confrontation is the bare minimum that you would need to do for every glaucoma patient, and that is something that will not find anything unless there is very significant damage, but that's something that you need to look at. A quick retinal evaluation if you have a dilated patient is important. Even undilated, you should try and take a look at the retina as much as possible, because very often glaucoma patients have associated retinal vein occlusions, or the retinal vein occlusion is a cause of a secondary glaucoma. Look for proliferative diabetic retinopathy. Look for changes on the macula. This is important because especially if you have an asymmetry of the vision that you cannot explain, it may be because of a macular scar, which is related to trauma. It could be because of cystoid macular edema, which could be related to either disease or drug. So when you look at the evaluation of a glaucoma patient, you have to remember that you have to classify this patient as having primary disease or secondary disease. And the only way you can classify the patient as having secondary disease is if you have actually looked and ruled out every other cause. Classify it as open and closed. And the few important things that you need to rule out is whenever you have a unilateral open angle glaucoma, carefully rule out a secondary cause. You can get unilateral POAG, but it is rare. A secondary cause needs to be ruled out before you commit to saying that this is a unilateral primary open angle glaucoma. If your vision does not correlate with the disc finding, look for coexisting disease, because you have to be able to explain any decrease in vision in a glaucoma patient before you finally conclude that it is because of glaucoma.